Hello everyone, my name is Molly Cooper. I am a dental hygienist. I graduated in the spring of 2024, and since then I have worked in pediatric practices mostly. I have also worked in general practices, so I've also seen, adults and geriatric populations, but I do specialize in pediatrics and also special needs with pediatrics. So today, a topic that I see a lot in my practice is airway obstruction. It often goes undiagnosed and it can lead to negative effects throughout child development and their adulthood. So today we're talking about airway obstruction in pediatric patients and the impacts of airway obstruction on oral health and oral facial development. So what is airway obstruction? It is the interference with normal airflow through the upper airway. It can be partial or complete, temporary, sometimes like little asthma attacks, or chronic, like emphysema or RSV. Commonly involves nasal passages, the pharynx, or soft tissue structures, and often leads to compensatory mouth breathing problems or patterns. May occur during wakefulness, sleep, or both. In my experience, I've seen it more during sleep. Frequently underdiagnosed in pediatric practices. A lot of times, the pediatricians will just kind of brush it off because they don't think it's that big of a problem, or it's maybe just a developmental thing that they go through. So, a lot of times, it's underdiagnosed, saying, like, oh, they just get strep or they just get ear infections. So, in my practice, we do a lot of referrals to ENTs to get them adequately and effectively diagnosed quickly so we can try to reverse it if possible. Why this matters: it directly influences the craniofacial growth and facial symmetry. It impacts dental alignment and occlusal development. It affects breathing quality during sleep and wakefulness. It can contribute to sleep-disordered breathing and systemic effects, and it often progresses silently until visible oral or facial changes appear, and it plays a key role in long-term oral and overall health. So the prevalence of airway obstruction, most commonly found in pediatric populations, frequently associated with mouth breathing. That is like the number one sign that I see most often. It can also be linked to sleep disorder breathing, which we will talk about that later, especially with behavioral changes. If kids not getting good sleep, they never get deep sleep, you will be able to tell that in their behavioral changes and acting out, things like that. Many cases remain undiagnosed. A lot of times we have to advocate for our patients or let our parents know that they need to push for these diagnoses so the kid can get back on the right track. It can be seen across various age groups. Let's say if we didn't get it diagnosed while you were a child, it can delete into teenage years and adulthood. And it is increasing awareness in dentistry. So what I thought was interesting was, from what I can remember in my program, just dental hygiene program, we focused a lot over many, many different things, mainly general dentistry, but whenever we were learning about airway obstruction, we learned over different things as far as like asthma, RSV, COPD, things like that, but not really to the extent of what to look for in pediatric patients and the developmental things that can happen with our kids. So since I've been working hands in hands with my dentist, we just started a new practice, last fall, and he has done many studies over this. It has been a great education tool. So this is why I wanted to talk about this, because we don't really go over it as in depth as I would like to. So here right now we're going to look over the normal airway anatomy. So you can see we have the nasal cavity right there near the tongue, the oral cavity, so you can see the nasal sits above the oral, the tongue's right there, and then along the throat we have the pharynx, the epiglottis, the larynx, and then the trachea leads to the bronchus, and then the lungs, the diaphragm. So the nasal cavity filters and humidifies the air, and then the pharynx serves as an airway passage. The tonsils and adenoid affect airflow. That will be important. The tonsils and the adenoids, the tonsils sit right below the kind of the tongue area, and the adenoids are a little bit higher up. And a lot of times, if a patient does have airway obstruction, this is pretty much number one treatment, is try to remove the tonsils and adenoids to try to clear that airway. The tongue position also influences the airway space, so we're going to talk about tongue positioning as well. And the soft palate supports airway function. This is important whenever we're talking about our patients with cleft palate or cleft lip, and how shallow or vaulted the soft palate or the hard palate is of the mouth. And all these structures must work together. So here we have the difference between nasal breathing and mouth breathing. So nasal breathing is the ideal pathway. It filters, warms, and humidifies the air. Think about your nose with all the filaments and hair that you have in there that tries to catch all the bacteria, versus if you were to mouth breathe, there is no filtering in there. It just goes straight to the airway. So mouth breathing bypasses the filtration, often leads to a dry oral environment, which is very bad. Our mouth is a moist place. With it being moist, it does offer a level of protection, because in our saliva we do have minerals and antioxidants that can kill bad bacteria. And once our mouth starts to dry out, then it just harbors a lot of harmful bacteria. And this often leads to obstruction of the oral and facial development. So here's a little picture for you. So on the left we have a mouth breather. So you can see the increased mandibular plane angle. Mandibular is the lower arch. So like the jaw right here, your lower teeth. And then the maxillary is your top teeth right here. And then we have increased total facial height. So you can see it's longer as compared to the nose breather. And decreased posterior facial height. So posterior meaning back right here. So it's kind of squished a little bit. And then on the right we have the nose breather. You can see there's proper alignment of the upper and lower jaw. There's no really pushing back here of the jaw. It is nice and straight. There's alignment of the teeth, because we will also be going over occlusion and how the different arches sit together, so we can see different classes of occlusion. And the facial height and mandibular plane angle within the average range. Roll of the tongue. This is very important. This is also why we like to discourage our patients from using any kind of non-necessary oral soothing habits, such as thumb sucking, passy usage, bottle usage past the age of 3, because that is whenever we can occur things such as tongue thrusting, or the palate to be raised, or our teeth to be flared out to the side. This all affects the airway. And this is also a recommendation by the ADA, the American Dental Association, to stop all kind of non-necessary occlusal habits. So the roll of the tongue supports normal growth of the maxilla, that's our upper arch, through resting posture, and maintains proper airway space when positioned on the palate, meaning the roof of our mouth. It guides normal swallowing and speech development. I don't know if you've ever seen any of this, but speech development, a lot of kids who go to speech therapy, they do have what is called tongue ties, or a thick frenum attachment of their tongue to the floor of their mouth. A lot of times people have to get those snipped. Let's see, it helps stabilize dental arches and occlusion. So think if a patient is tongue thrusting like that, it will push the upper anteriors, our upper teeth, out like that. And it acts as a functional mold for the craniofacial development. So here we go. Here's some postures of the tongue. So the proper posture, you can see all the way on the right, is the tongue rests on the palate. So it reaches the roof of our mouth, like that. Lips remain closed at rest, so no mouth breathing. And then we also have 2 more improper positions of the tongue. So one of those would be the low tongue position. We can see that more clearly with the picture on the left. And this is whenever the open mouth posture is most common with that. It reduces the palatal support. So think about if you don't have the tongue to constantly push against the roof of your mouth, then the palate is going to become very shallow. And over time, it's going to mold to your tongue. So even if you do try to practice your tongue resting on the roof of your mouth, it's going to be very hard because your palate has already molded to that shallow posture. This can lead to developmental changes. So let's see, we have a tongue drives good oral health, and one of the basics of good oral health is having proper tongue resting position. All right, so here we have causes of airway obstruction. Airway obstruction is multifactorial. It includes structural causes, includes inflammatory conditions such as asthma, includes behavioral adaptations such as mouth breathing, and often multiple factors are present and it requires comprehensive evaluation. So we as dental professionals might be the first ones to see any kind of signs of this and then refer our patients out. Sometimes the pediatricians notice it, or if the parents are really on top of things, advocating for their children to get evaluations by their different specialties, such as their pediatricians, and the last stage is to be seen by ENT, an ear, nose, and throat specialist for their child, because they are the ones who do the referrals out to speech or getting the tonsils and adenoids removed. Now, if it is not so much a blockage of the airway as it is a teeth concern, then us as dental professionals will refer out to an orthodontist to see if we can get the occlusion of the teeth right to open up the airway. So here we have enlarged tonsils and adenoids. This is the most common pediatric cause. The enlargement blocks the airway. It's more noticeable during sleep because thinking whenever you are laid all the way back, your throat kind of collapses on itself. So then if your tonsils and adenoids are very swollen or enlarged, the airway is going to be really hard to open up. So right as we're sitting upright, we have the most clear way of breathing compared to laying down where everything's kind of collapsed. So that's whenever kids don't get good sleep, is whenever they're laying on their back and they already have enlarged tonsils and adenoids. It is associated with snoring. So same thing for adults. If you snore a lot, it's more, acceptable to sleep with higher pillows to where you kind of rest sitting up a little bit so your airway is not as blocked. Leads to mouth breathing and can be observed clinically. So here we have the different tonsil classes. So up on the upper right, we have tonsil class 0, which is they have been removed. The tonsils have been removed. And you can try to see this whenever you are doing an evaluation of your patients. It's hard to see whenever the mouth is just open like that. So you need to have the patient go, ah, and stick out their tongue, because whenever they say ah, then the uvula and the soft palate naturally kind of go up a little bit. That's the easiest way to see this. Tonsil class 1 is tonsils hidden within the tonsil pillars. So there's 2 pillars in the back of our throat, and the tonsils sit right in between. So you can kind of see, especially in class 0, whenever they're removed, you can see the posterior pillar and the anterior pillar. And then in class 1, you can see the tonsils are kind of hidden in between there. And then class 2, they're extending out towards the uvula. Class 3, they are beyond the pillars, so the pillars are nowhere to be seen, almost touching the uvula. And then number 4 is whenever they are completely covering up the uvula. And whenever between these classes, ENTs usually wait until they see class 3 or 4 to go ahead and remove. So if you see any patients that have class 2, go ahead and try to get them that referral before it gets too bad. Alright, so let's go over asthma. So asthma is a chronic inflammatory condition of the lower airways. It causes airway narrowing and increased breathing resistance. So on the left, I have a diagram of the airway and the tissues that support it. So we have a normal airway on the left, an asthmatic airway, and then there's the airway during an asthma attack. So if your patients have asthma, the middle picture is what they already have, and then once an attack flares, then that's how small the airway has gotten. So it causes airway narrowing and increased breathing resistance. Symptoms include wheezing, coughing, shortness of breath. It can be triggered by allergens, exercise, or respiratory infections. So most common asthma attacks are seen during the seasonal changes. If they already have seasonal allergies, it is then very common for them to get an attack during the spring or the fall, especially with the nice warm weather with our pediatric patients. They like to go out and play. And let's see, it can influence overall breathing patterns, including the mouth breathing. So here's another very important one, the deviated nasal septum. So this not only has to do with just the throat airway, it also includes our nose airway as well. So a lot of nasal septums, it can be due to just development, that they were born this way, or it could happen from a traumatic event such as breaking a nose. So deviated nasal septum is structural abnormality. It reduces the nasal airflow. It may be congenital or acquired, and often undiagnosed in children, and it leads to breathing imbalance and contributes to the obstruction. So on the upper graphic of the picture, we have the normal nasal septum, so you can see it from this view. So it is kind of hard to see straight on. That's why it's not as diagnosed with children. And then you can see the lower picture, the deviated septum right there, along with what it would look like if the cartilage wasn't to be seen in the nose. So see on the upper one, the upper graphic, the septum leaves good space on both nostrils for airway to get there, and then in the deviated one, the right nostril right here is closed. So this one, it can be contributed, obesity can be contributed to airway flow just due to the excess soft tissue in the upper airway space. Increases airway resistance, especially during sleep. Imagine the weight on your lungs whenever you're laying down. The fat deposition around the neck and the pharyngeal structures reduces airway patency. It's associated with higher risk of sleep disordered breathing and can worsen mouth breathing patterns and airway collapse risk. It may contribute to chronic low oxygen levels during sleep, which is known as hypoxia. Okay, so here is a graphic of the skull or the cranium. The lower light blue part is the mandibular arch, also known as the jawbone. And then we have the maxilla is the light pink, and then the temporal bones right here is the purple. And then you can kind of see the nasal septum there in the dark red, and then the nasal fossa in the kind of darker blue there. So narrow airway structures, very narrow, especially imagine how much more narrow they would be if you have a deviated septum. And then it is more genetic predisposition, so genetics play a huge role in the airway. And then we have a mid-face deficiency, and it affects the airway size. So this is found in people that do have the airway conditions. Next, we are going over congenital conditions. Congenital means that they are present at birth. They can affect the airway structure. They highly impact feeding and breathing, especially if, as far as a newborn, if they're breastfeeding or bottle feeding. They influence the facial development, because think about how much oral habits the child is doing as far as sucking to try to get milk out of the breast or the nipple or the bottle. And then require early intervention and often need disciplinary care. So the number one congenital conditions that we find that leads to the most severe airway obstruction is the cleft lip and palate. So cleft lip and palate is congenital condition involving the incomplete fusion of the lip and or the palate. It can affect the hard palate, the soft palate, or both. So the hard palate, if you kind of go over your tongue with the hard palate right now. The hard palate is the most anterior part of your palate that touches the back of your teeth, a little bit under the nasal cavity right there. It's hard, and then the farther you go back to your throat, there's a little dip where you start to not feel the bone right there, and then it gets really soft. So that's the difference between those. So the soft palate is most posterior, hard palate is most anterior. It creates an opening between the oral and nasal cavities. This is most seen with the cleft palate, and this is the most severe. And then it may interfere with feeding, speech, and normal airway function, especially with a bottle feeding, because you have to be very careful with our cleft palate patients not to let any kind of milk go into the nasal cavity. So a lot of times they have to have a prosthetic placed, and we will look at that later. This often requires surgical repair and long-term multidisciplinary care, and it can influence the maxillary growth and dental arch development. So here is a cleft palate classification. So here we have the cross-section of the maxillary arch, and then looking from the bottom up, we have the nose, the lip, the gums, and then the palate. So on the upper right, we can see a normal lip, and then just a unilateral cleft lip, bilateral cleft lip, and then a unilateral incomplete cleft. This is kind of the best scenario if you were to have a cleft lip or palate, is the unilateral incomplete. So if it is a complete cleft, it'll go through the palate to the lip into the nasal cavity. So down here on the bottom right, you can see the inferior position. We have a normal palate, cleft lip, bilateral cleft lip, cleft palate, which cannot be seen unless you were looking inside of the mouth, a unilateral cleft lip and palate, so it travels from the nasal cavity, lip, all the way to the palate, and then a bilateral. If the patient has bilateral, usually that is a surgical treatment is done. So effects of cleft conditions is disrupted nasal and oral separation affects normal airflow patterns. It increased the risk of feeding and swallowing difficulties in infancy. Altered speech development due to structural and functional limitations, and a high likelihood of maxillary growth restriction and midface deficiency. So we will look at that later, but usually, I don't know if you're aware of people with cleft palate or cleft lip. Usually, since it's kind of a shortened palate, usually the midface here is kind of pushed back, like it's very flat right here. Increased evidence of malocclusion of the teeth, including crossbites and crowding, and long-term need for orthodontic, surgical, and speech interventions. Next, we will be going over Down syndrome, which is the genetic condition caused by trisomy 21. It is characterized by distinct craniofacial and oral features. Midface hypoplasia contributes to reduced airspace. Relative macroglossia, which is a large tongue appearance, may affect the oral posture. And hypotonia can affect muscle tone and oral function, often associated with an increased risk of airway obstruction. So here are just some pictures of a patient with Down syndrome. So you can see the very vaulted palate right here, along with the kind of bigger teeth. A lot of times you can see supernumerary teeth, which just means extra teeth found here in the mouth. And a lot of times with that narrow arch, there's going to be lots of crowding and malocclusion there, as you can see in A or B. So here are the oral and airway effects of Down syndrome. Here is just a little graphic I've showed to show you what the occlusion most likely looks like in our Down syndrome patients. So like I said, with a narrow U-shaped, instead of a U-shape, it's more of like a V in our Down syndrome patients. they will have the tongue thrusting because of the macroglossia, the enlarged tongue, try to thrust open these teeth. So it's an open bite in the anterior. And I know this picture doesn't really show a crossbite, but usually it's a crossbite in the back or the posterior. It is an increased prevalence of mouth breathing due to reduced airway space, higher risk of obstructive sleep disordered breathing, tongue posture often low and anterior, meaning close instead of back, due to oral crowding, delayed or altered eruption patterns contributing to malocclusion, increased risk of periodontal disease due to oral environment challenges, such as dry mouth, and combined structural and functional factors affecting long-term oral health. So what happens next? If a patient does have airway obstruction, the first thing is that they will shift to mouth breathing from nasal breathing. So this occurs when nasal airflow is reduced or insufficient. The body compensates by increasing oral airflow for an adequate oxygen intake. It can begin as a temporary adaptation and then become habitual over time, often reinforced during sleep when airway resistance increases, and leads to persistent open mouth posture even at rest. It becomes a learned breathing pattern that may persist without intervention. So now we have a low tongue posture. So remember the graphic we saw earlier where you want the proper tongue posture to be resting against the hard palate. So low tongue posture, the tongue drops from the palate, you lose the maxillary support, it alters the muscle balance, reduces airway stability, contributes to a narrow arch, and impacts swallowing patterns. Now we have a tongue tie at ankyglossia. What I was talking about before is the frenum tag connecting the tongue to the floor of the mouth. So the restriction of tongue movement due to tight lingual frenum, it limits elevation and mobility of the tongue, most likely present at birth. It may interfere with normal oral function, often goes undiagnosed in mild cases, and can affect speech, swallowing, and feeding. Impacts proper tongue posture because if the tongue is tied, not only does it affect speech, but you cannot achieve the proper tongue posture of it resting on the hard palate. It can influence airway development. And then we have the low tongue posture, mouth breathing, difficulty with swallowing, speech challenges, a narrow maxilla development, and potential airway restriction. So now we will be talking about more frenum attachments. So we have already talked about the lingual frenum, which is the tongue tie. Now we also have a labial frenum, which is the roof, that one that connects our top lip, and also we do have a few on our bottom lip, along as on the sides as well. So a lingual frenum connects the tongue to the floor of the mouth. The labial frenum connects the lip to the gingiva or the gums. Abnormal attachments can restrict the movement of our lips, tongue, all of our speech organs. It may affect oral function and development, can contribute to spacing or recession, important to evaluate during exams. Treatment may include a frenectomy, which is the snipping of that tissue, and often part of interdisciplinary care. So we have altered muscle function is what happens next. So we have mouth breathing, tongue ties, such as those, and then if those are not fixed, it leads to altered muscle function. So we have reduced lip seals, where your lips are not able to completely close, leads to decreased orbicularis oris tone over time, which is our lip muscles. Tongue rests low and forward instead of on the palate. Increased activity of accessory muscles to maintain oral airway, the accessory muscles are such as the buccal or the masseter muscles, such as grinding, clenching, bruxism, attrition, things like those. Improper swallowing patterns, often tongue thrust-like behavior, muscle imbalance between cheeks, lips, and tongue, and functional adaptation reinforces the abnormal craniofacial growth patterns. So now we will be going over the non-nutritive functional habits, such as anything that our mouths are doing extra besides eating, talking, things like that. So in our pediatric population, we can see thumb sucking and pacifier use. So this is the most common habits in early childhood. It provides self-soothing and neuromuscular regulation, considered normal when discontinued at an appropriate developmental age, and prolonged use may apply continuous pressure to the developing oral structures, and it can influence dental eruption patterns and arch development. So if a patient is sucking their thumb, it'll lead to a much narrow palate to where the teeth, instead of resting in the natural U shape, will start to become a V, and then you will have lots of crowding in the anterior. It's pretty much a domino effect. So as soon as you get the crowding in the upper anterior, then the natural palate, what I see most often is you will have the 4 anterior teeth, 7, 8, 9, 10. Usually the canines of our kids usually don't come in, their adult canines don't come in until about 10 or 11 years of age. And if the palate is too narrow to allow our canines to come in, lots of times you will see just the tips of the canines trying to push through the gums, but not fully erupt. And if they do come through, they're kind of resting on top of our lateral incisors, which would be 7 and 10. So lots of times we will have to refer our patients out to an orthodontist to try to get a palatal expander, or they will start orthodontics very early to try to increase that space for the canines to come in. This may contribute to open mouth posture and altered tongue position. Next, we have effects on oral facial development. So continuous anterior pressure can displace the incisors and disrupt eruption patterns. It restricts normal maxillary width development, contributing to a narrow arch. It increases the likelihood of anterior open bite and formation, because if we are also sucking on our thumb, not only do we have a narrow palate, but those upper teeth begin to flare. So if they begin to flare, let's say our bottom arch isn't, whenever we go to close our teeth, you will see the teeth don't fully come together like that. In resting, they are almost like this. It can alter the normal palatal shape, often leading to a high vaulted palate, disrupts the balance of the oral musculature, the tongue, lips, and cheeks, and may influence long-term occlusal stability if habit persists during growth. So if they don't stop by age 3, then the more negative outcomes that will happen from the thumb sucking or pacifier use. So the impact on airway and function. It encourages persistent low tongue posture, reducing the palatal support. It promotes open mouth resting posture and habitual mouth breathing. Decreased nasal breathing efficiency during growth and development. That alters normal orofacial muscular balance needed for airway stability. And it can contribute to narrowed maxillary arch, reducing normal airway space. Oral airway space. May reinforce dysfunctional breathing patterns if the habit persists. Next, we have management and prevention. So early education for parents on age-appropriate habit cessation. So I always talk to all of my patients as soon as they come in. Lots of times we do have parents bringing our kids in before age of 3, which is what is recommended pretty much to get. It's not so much a dental visit for the baby as it is for education for the parents. So I always tell the parents, as far as thumb sucking, pacifier use, the ADA recommends that we stop that by age 3. Positive reinforcement and behavior modification strategies. We have identification of triggers such as stress, fatigue, or anxiety. So I try to encourage the patients to limit the amount of use. So let's say the patient just likes to suck on it 24/7, stress, anxiety, things like that. Then I try to convince or educate the parents on replacing those habits. Maybe it could be like a hand fixation instead of an oral one, or if they have to use it to go to sleep, once the patient has fallen asleep, if the parent will just remove the passy from their mouth or take the thumb out of their mouth. Now, I know they need to sleep, the parent needs to sleep, so it can be hard if that habit persists past the age of 3. Use of reminder techniques such as banding the thumb, bitter nail solutions, or pacifier weaning plans. Sometimes we can put acetone on the thumb to try to discourage the patient from sucking their thumb. And then we also have regular dental monitoring to assess the developing occlusion and oral habits. So we have thumb sucking, which applies to continuous anterior pressure, contributes to anterior open bite. We have passy use, which prolonged use beyond age 3 can restrict the maxillary width and alter palatal shape. Bottle feeding, extended use, encourages forward tongue positioning and improper swallowing patterns. Sippy cup use limits the normal tongue elevation and may reinforce immature oral motor function. Tongue thrusting exerts forward pressure during swallowing and contributes to open bite and instability. Nail biting, lip sucking alters the muscle balance and can affect incisor, our front teeth, positioning over time. And prolonged soft diet reduces the masticatory stimulation, which is what we used to bite with, needed for proper jaw development. So delayed weaning of habits prolongs exposure to forces that shape developing oral structures. All right, now we have effects on oral facial development. So this alters normal craniofacial growth patterns during key developmental stages. It contributes to a vertical facial growth pattern, which is known as long face. It reduces the transverse maxillary development, leading to the narrow dental arches, and promotes high vaulted palate due to altered tongue posture. So it reduces the balance of facial muscle lips, cheek, and tongue, and increases malocclusion and orthodontic discrepancies. So long face syndrome is characterized by the increased lower anterior facial height, often associated with chronic mouth breathing. Inadequate lip seal contributes to open mouth. Vertical growth pattern of the mandible, our jawbone, becomes more dominant, and narrow maxilla and high arched palate are commonly present. It may be also accompanied by dental malocclusion and poor occlusal stability. Next, we have the narrow maxilla, which is reduced transverse width of the upper dental arch, commonly associated with chronic mouth breathing patterns. Lack of tongue pressure on the palate limits normal maxillary expansion, may result in posterior crossbites and dental crowding, can reduce nasal airway volume due to maxillary constriction, and often develops during active growth periods of childhood. Vaulted palate, we've kind of already gone over this, the increased vertical height of the palate, commonly associated with mouth breathing. It reduces the lateral tongue pressure, allowing palatal collapse upward. Often increases alongside or occurs alongside narrow maxillary arch development. As you can see, this is all kind of a domino effect. So once it's gotten to this point, it's very hard to reverse, and it can decrease the oral cavity volume and functional space, frequently associated with malocclusion and crowding. And then malocclusion is just the misalignment of teeth due to altered growth and functional patterns, commonly linked to mouth breathing and low tongue posture, crowding, spacing, anterior open bite, and it can also contribute to posterior crossbites. Disruption of the muscle balance affects occlusal stability, and it also develops during the active craniofacial growth periods. So here is the Engels classification for occlusion. Class 1, which is normal, and the most common, is the maxillary mesiofacial cusp, located in the mesiofacial development of the groove of the first mandibular molar. So this is a lot of big words here, but basically the maxillary right here, let's see, how am I going to do this? The maxillary is back just one step for the posterior, but it still is in the first, it's a little over. So then we have class 2, where you have the maxillary arch, you have a big overbite, and then class 3 is an underbite. So for class 1, we refer to this as mesognathic profile. Class 2 is retrognathic profile, and class 3 is prognathic profile. So bite changes. We have altered intercuspation, the cusp of the teeth, due to disrupted dental and skeletal development. And then it can present as an anterior open bite or deep bite patterns. We have posterior cross bites commonly associated with maxillary constriction. A reduced functional efficiency during chewing and swallowing may contribute to TMJ, which is the jaw joint right here, strain over time, and often reflects long-term airway and habit-related influences. So, number one thing is early intervention. Growth is still modifiable in the early ages, prevents long-term complications, improves airway function, supports proper development, and reduces need for extensive treatment, and emphasizes early detection. So next we have xerostoma, which is the clinical term for dry mouth. This is the number one thing that happens with mouth breathers, is the tissues of the mouth start to dry out. So the oral health effects of xerostoma: mouth breathing alters oral environment, reduces the moisture levels, impacts saliva distribution, increases disease risk, and affects comfort and function, and common in pediatric patients. My mouth is getting dry just talking about it. Next, we have the causes of xerostomia. Is the chronic mouth breathing, open mouth posture, saliva evaporation, reduced salivary pooling, airflow exposure, and nighttime dryness. So you can see kind of the dried out tongue and the chapped lips. The role of saliva in the mouth. Saliva is made up of minerals that buffers the acids in our mouth. So this is very important in reduction of cavities. So how cavities form is the natural bacteria in our mouth is very good. That's found in saliva. As soon as we eat anything that we eat, mostly besides water, anything is considered acidic. Now, the acidity, the pH level of sugar and carbs is much higher in acidity than it is, like, let's say, vegetables or whole grain, stuff like that. So whenever we eat those high things, then the higher the acidity level, the good bacteria in our saliva will buffer that out. So it's very important that we keep our mouth nice and wet so it can try to buffer out the acidity, because once the acid starts to attack our enamel and our saliva isn't there to buffer it off, then this acid starts to do an acid attack on the enamel of our teeth, eating away the enamel, and then that's what leads to cavities. Saliva also aids digestion. It lubricates the tissues and protects oral structures. The negative effects of xerostomia: increased caries risk, which is cavities, plaque accumulation, gingival inflammation, halitosis, which is the clinical term for bad breath, oral discomfort, and difficulty eating or speaking. Clinical signs of xerostomia is dry, sticky mucosa, which is the lining of our gums, our cheeks, and our lips, lack of saliva pooling, cracked lips, fissured tongue, which you can see on this graphic. Fissured tongue is the kind of deep line on the midline of the tongue, increased plaque, and red irritated tissues. The caries risk is reduced buffering capacity of the saliva, increased acidity overall in the mouth, faster demineralization of the enamel, higher bacterial activity, the negative bacteria, and rapid decay protection, and it's difficult to manage after a mouth pH has already reached that acidic level. So the management of xerostomia is to encourage often hydration. So it is great that water consumption is now trending, especially with kids. Almost every kid has a little Stanley cup. So as long as there's water in there, that is the best thing for them. Fluoride treatments, xylitol products, which is a sugar alcohol, so it doesn't have the properties of regular sugar, so it kind of helps reducing the cavities but still giving the children that sweet flavor. Saliva substitutes such as a lozenge, improved oral hygiene, and also number one is to address the airway cause. Alright, so now we will be talking about sleep disordered breathing. It is a spectrum of conditions affecting the normal breathing during sleep. It ranges from primary snoring to obstructive sleep apnea. It is characterized by partial or complete upper airway obstruction. It leads to disrupted sleep architecture and reduced oxygenation, common in pediatric patients with airway or craniofacial risk factors. It is often undiagnosed despite significant health impacts. Signs of sleep disorders: loud snoring or noisy breathing during sleep, pauses in breathing or gasping episodes, which is apnea events, restless sleep with frequent repositioning, daytime fatigue or difficulty concentrating. This can also be missed if a lot of times they just run to ADHD or ADD in kids who have trouble concentrating. Morning dry mouth or sore throat, and mouth breathing and open mouth posture during sleep. Behavioral effects. With children, they are hyperactive, irritable, and have attention difficulties, learning challenges, and reduced academic performance, mood changes, and increased daytime sleepiness. With adults, it is chronic fatigue and decreased daytime alertness, difficulty concentrating and reduced work performance, and for both, the mood is unstable and reduced quality of life due to poor sleep. So even though they might be getting 8 hours total of sleep a night, it's not good, effective sleep. They are constantly, their body is still in a fight mode of trying to get airway and oxygen to reach their brain. So, what can we see in clinic? Number 1 is the assessment. We need to observe the resting lip posture, closed or open mouth breathing. So, whenever I first sit my patients down, I give them a minute. I kind of have this rule of thumb where I talk to them for 5 minutes. And while I'm talking to them, getting to know about their social life, I'll see how they talk, how they breathe, especially sitting up versus laying down. In our clinic, it's really nice because we have TVs on the ceiling. So I kind of give them a minute to watch their movie while I'm setting up everything, even though it's already setting up, so I can see how they naturally breathe. And then we assess the tongue posture and available space in the oral cavity. Note signs of mouth breathing, such as dry tissues or gingival changes. Evaluate the palatal shape and maxillary arch width, and review the medical history for ENT issues, allergies, or sleep concerns. And then you want to identify the red flags suggesting sleep disordered breathing, such as the irritability or the attention difficulty. What to look for? As far as extraoral findings, which is outside of the mouth, you want to look for open mouth resting posture or incomplete lip seal, long facial appearance or increased lower facial height, dark circles or tired appearance under eyes, forward head posture and chronic mouth breathers, and audible mouth breathing or noisy nasal airflow. Intraoral findings, which is inside of the mouth, dry oral tissues and reduced salivary moisture, enlarged tonsils, high vaulted palate, dental crowding, low tongue posture, gingival inflammation, and signs of parafunctional habits, which would mean like grinding or clenching. Treatment. So if our patients do have these types of things, what we refer to would be to refer to an ENT for evaluations of tonsils, adenoid, or nasal obstruction. Refer to a pediatrician for systemic sleep or breathing concerns, such as asthma. Refer to a sleep specialist for suspected sleep disordered breathing. Refer to an orthodontist for craniofacial development and occlusal concerns. Refer to myofunctional therapists for tongue posture and functional retraining. And then you always want to document clearly where we are referring them to. So one of the treatments would be a palatal expander. I see this a lot with our kids. It's a medical management of underlying causes, an ENT intervention for enlarged tonsils and adenoids, and then, myofunctional therapy to retrain the tongue posture. And then here is the picture of the palatal expander. So it is placed on the 6-year-old molar, so they have to be at least 6, and then also the first baby molar right there in the narrow arch. So before, you can see how narrow the arch is versus after. So it is heavily compliant on the patient and parent compliance. Usually the parent has to crank the palatal expander once a night, and then over time it will increase that space. And usually this is pre-braces. So as soon as they get the space that they are wanting to achieve, then they will place braces to keep that space so it doesn't collapse again. So this is as far as like tongue posture, the myofunctional therapy. It retrains oral and facial muscle function, focuses on correct tongue posture, swallowing, and breathing, aims to restore nasal breathing and proper lip seal, and it uses guided exercises to improve muscle coordination, often used in conjunction with orthodontics. Now this case is very interesting. It is called the Creed twins. So we have Ben and Quentin Creed. They are identical twins used for comparison, same genetics, but different treatments. Both had crowded or irregular teeth. Allows focus on environmental versus treatment effects. It highlights the impact of the airway and growth guidance and demonstrates differences in facial development. So, one of the twins had traditional orthodontic braces treatment. It included tooth extractions to create space, braces used to align teeth, focusing on straightening teeth, and treatment performed after crowding developed, so it does not directly address the growth patterns. And then the other twin had an orthotropic or growth-guided treatment. So the second twin was treated with orthotropics, no extractions performed, focused on jaw expansion and growth, encouraged proper tongue posture, focused on guiding jaw growth rather than removing teeth, and encourage proper tongue posture and nasal breathing, and it aims to expand the maxilla naturally. So this treatment targets the underlying cause. So the differences in the outcomes. The traditional orthodontic treatment resulted in a flatter facial profile, right here, narrow smile and arch width. The orthotropic treatment showed forward facial growth, broader smile and improved facial profile, improved facial balance and airway support, and the differences are noticeable into adulthood. So the clinical relevance of this study is that airway and oral posture influence development. Treatment approach can impact facial growth. Early intervention is critical, supports importance of the tongue posture, and highlights role of environmental factors. And it also reinforces the need for comprehensive assessment. So here's the picture of the twins. So you can see orthodontia, which was the teeth was removed for lack of space and braces placed. So you can see kind of the flattening of the midline, and the jaw isn't fully developed as compared to the twin who got the orthotropic, which was the palatal expansion and then the braces placed. So no teeth removed on him. So you can see more development of the jawbone and the midline of the face versus the twin who had to get the teeth removed. So, after all of this, our role as a hygienist is to identify clinical signs of suggestive airway dysfunction during the routine exams, document extraoral and intraoral findings, posture, occlusion, tongue position, recognize the risk factors for sleep disordered breathing in pediatric patients, provide patient and caregiver education on oral airway connections, and communicate concerns clearly and professionally within the scope of practice. And we also want to initiate the appropriate referrals to medical and dental specialists. So a lot of times, I don't know the accuracy of this, but in Bartow County with our ENT specialist, a lot of our parents will have trouble. We will see class 3, class 4 of the tonsils, remember, where it's touching the uvula or completely covering it. And a lot of our parents will say the ENTs will not remove the tonsils or the adenoids unless they've had strep 7 times within a year. That's a little, to me, it seems very extreme to let our kids get that sick before treatment is proposed. So what I would recommend as a parent or as a professional giving advice to the parent is to advocate for their patients, to say to the ENTs, my child is not only having trouble breathing, this is affecting their sleep, this is affecting their facial development, And cause of that is also causing them to act out during school to their parents. It's negatively affecting their learning or their social development as well, and try to get that pushed as far as ENT removing tonsils and adenoids. Asthma is a different thing as far as getting the right medication for that, which that isn't a hard diagnosis. But the main diagnosis is getting the tonsils and adenoids helped, and then also orthodontics try to this is completely up to the orthodontist on what they think is the best treatment plan for the patient. But as we can see in the past, our twins that we went over, it is very, I would prefer the palatal expander, even though it might be a little bit harder than just getting some teeth removed and placing braces. Overall, it has a better end result towards the patient. All right, well, that is all I have to talk about today. Here are my references, and thank you so much for joining me today talking about airway obstruction in our pediatric population.